Welcome back to another thrilling lecture in our Stroke Made Simple series. Today we are going to go over Chapter 5, which basically talks about the different types and mechanisms that can cause ischemic stroke. Again, all of this information is available on the book, within the book Stroke Made Simple. So let's go over our objectives. Before we start, please hit the like and subscribe button so we can get more viewers aware of this channel. So the purpose of this chapter is to review the various subtypes and causes of acute ischemic stroke. So as we talked about on the last lecture, or the last few lectures, is a stroke is caused by sudden onset of compromised brain function from either a blocked vessel to a region of the brain or a leaking blood vessel causing hemorrhage in the brain. So ischemic stroke, we discussed this earlier, is caused by an occluded vessel. Hemorrhagic stroke is caused by a ruptured vessel within the brain or covering the surface of the brain. Again, ischemic stroke accounts for 87% of stroke. It's the vast majority of stroke, whereas hemorrhagic stroke accounts for only 13% of all stroke. This is divided into bleeding within the brain and subarachnoid hemorrhage, which is bleeding on the surface of the brain. A couple lectures ago, we talked about the concept of the core infarct, which is irreversibly damaged brain tissue, and surrounding that is an ischemic penumbra, which is tissue that we can still salvage so long as we can restore blood flow to the brain. Remember, that's our primary goal in stroke treatment, or rather ischemic stroke treatment, is the restoration of blood flow and reperfusion to the brain. So when we talk about the different classifications of stroke, again, we're talking about ischemic stroke caused by an occluded blood vessel versus hemorrhagic stroke caused by a leaking blood vessel. Today, we're just going to focus on ischemic stroke. Hemorrhagic stroke, I believe, is going to be the next lecture. But there are different categories or causes or mechanisms for ischemic stroke consisting of large arterial atherosclerosis, small vessel disease, cardioembolic disease, cryptogenic stroke, there's a newer term, ESUS, and we'll talk about that in a second, and other causes. Again, the paramount goal of all acute ischemic stroke therapy is to preserve the ischemic penumbra by restoring blood flow to the brain and reperfusing these threatened regions of the brain. So when we restore blood flow, all we have damaged is that initial core infarct, with restoration of flow to the ischemic penumbra and saving all this brain tissue from otherwise being infarcted. Remember, the core infarct consists of irreparably damaged cells. These will not come back. The penumbra consists of non-functional cells, which I consider to be sleeping. They're cells that can be reawakened if we restore blood flow to them. So if we restore blood flow to these cells, they can regain function again. Now, this is very important because we know over time, the thing that keeps this penumbra alive is called the collateral circulation. But that collateral circulation can only act for a limited amount of time. And as time proceeds, this ischemic penumbra gets smaller and the core infarct gets larger. As the core infarct enlarges and the penumbra decreases in size, we go from having a good functional outcome to a poor functional outcome. That's why it's very, very important to treat these patients as quickly as possible. So this is a really good example of the same thing again, is here's a clot in a vessel. If there's no collateral flow, all this territory is going to die. This is a core infarct. In this situation, only the tissue surrounding, immediately adjacent to this clot, dies. This is the core infarct, but look at all this collateral flow here. This collateral flow is maintaining the ischemic penumbra which surrounds the core. Remember, our goal in all stroke therapy is to remove this clot, restore blood flow to the penumbra, and get all this tissue back. Again, here's another example. Here's an occluded blood vessel. This is the right middle cerebral artery. We should all know this based on the last lecture. The tissue surrounding, adjacent to this core, or this occluded vessel, will have a core infarct. However, look at this. The anterior cerebral artery has collaterals that supply and connect to the distal middle cerebral artery branches. This is the ischemic penumbra, which is being maintained by this collateral circulation. Yet another example, we have occluded middle cerebral artery again. Here's the collateral circulation going up the anterior cerebral artery through leptomeningeal collaterals down into distal branches of the middle cerebral artery. By doing so, this area of the brain can survive. This area of the brain is called the ischemic penumbra, but we have to remove this clot to restore blood flow to this area of threatened but not yet dead brain cells. Here's yet another example. This is an occluded right MCA M1 segment. We could see this collateral flow coming down the anterior cerebral artery into the distal right middle cerebral artery distributions. This is the collateral circulation, and the tissue it supplies, again, is called the ischemic penumbra. Remember, core infarct is irreparably damaged, dead brain tissue. The ischemic penumbra is threatened but not yet dead brain cells. Our goal for acute ischemic stroke treatment is to restore blood flow to this penumbra and save this threatened region of the brain. So we're going to go through the different causes of acute ischemic stroke, different mechanisms. First, we're going to talk about is large vessel atherosclerotic disease. This accounts for 30% of all acute ischemic stroke. Then we're going to talk about other disease mechanisms such as embolic strokes of undetermined source called ESUS, cardioembolic stroke, small vessel disease, and other stroke-causing conditions. Now, embolic strokes of undetermined source is commonly referred to as cryptogenic stroke, but we don't want to use that term anymore, and I'll explain why in a minute. So large vessel atherosclerotic disease, this is a classic example. This is the carotid artery. You would see that there's plaque in the carotid artery. And where did this clot come from? Well, typically in atherosclerotic disease, it comes from an unstable plaque that ruptures and forms clot to either occlude this vessel or launch it distally into the brain. So the different causes or mechanisms of acute ischemic stroke, again, we're looking at them. ESUS, which was again called cryptogenic stroke, small vessel disease, which includes lacunar stroke, large artery disease caused by atherosclerotic disease, cardioembolic stroke, and other mechanisms. Again, ESUS stands for embolic stroke of undetermined source. It's the newer term for cryptogenic stroke. So we see that the vast majority of all stroke is of undetermined etiology, embolic strokes of an undetermined source, and atherosclerotic large vessel disease, followed by cardioembolic stroke, followed by small vessel disease, and everything else, or 5%, which comprise another 5%. Now, this is my mnemonic for the different mechanisms for acute ischemic stroke. The word is cause. And again, we're just seeing the different distribution with large vessel atherosclerotic disease and embolic strokes of undetermined source being the largest categories in this distribution. Now, we are going to talk about in the future the arterial distributions and what part of the brains they affect. But for now, I just want to concentrate on the mechanisms of what leads to acute ischemic stroke. Another thing we have to discuss is the concept of embolic versus thrombotic. Now, these two words are used in the stroke arena all the time and oftentimes incorrectly. So let's explain what this is. So an embolus is a blood clot that originates outside of the brain. So here we have a patient with AFib and a regular heartbeat forming clot in the heart, which is launched up into the brain. This embolic clot that gets stuck in these smaller blood vessels in the brain, this is a clot that originated in the heart and travels up into the brain. So this is an embolic clot or an embolus or a cardioembolic event, however you want to term it. As opposed to embolus, which originates in a different part of the body, thrombotic stroke occurs when a clot occurs locally within arteries in the brain or that supply the brain. And here we again have a plaque from atherosclerotic disease. We believe that these plaques destabilize, rupture, and allow clot to exude into the lumen. So an easy way to remember this is right out of the book again, is embolic means the clot arises elsewhere. Thrombotic is within the vessels of the brain itself, okay? Now, one thing, because we're talking about different mechanisms that could cause stroke and multiple different things pertaining to stroke, I strongly encourage you to adopt this mnemonic S plan, which stands for stroke plan. And this plan, whenever you're dealing with a stroke, you should consider all of these things, and all of these things considered together will help you understand stroke very well. So the first consideration, the S stands for source. Is this embolic or thrombotic? The second consideration is the pathophysiology. What is the etiology of the stroke? The next consideration is the location, what area of the brain is affected. The next consideration is the arterial territory, what arterial territory is involved. And finally, neuroimaging. I'll tell you right now that we don't care for stroke without neuroimaging. So when we're looking at the different sources, again, it's embolic versus thrombotic. Pathophysiology, this is that cause acronym again. Is it cardioembolic, atherosclerotic large vessel disease, undetermined etiology, ESUS, small vessel disease, or everything else? The location, what lobe or deep gray nuclear structure this is occur in? What arterial distribution is involved? And what does the neuroimaging show? So for example, let's go this case. Here we see that we have a left M1 segment occlusion. So this is the left middle cerebral artery. There's an M1 occlusion. Let's go through this stroke plan or S plan. What is the source? Well, most anterior circulation emboli arise from the heart, so we could surmise this is likely cardioembolic. Pathophysiology, we just said it's cardioembolic. Location, this is the middle cerebral artery, which supplies the frontal and parietal lobes. So when we look at our studies, we're looking at those regions. When we're examining the patient, we're looking for functions that arise from the frontal and parietal lobes. Which artery is involved? We know this is the middle cerebral artery. What does the neuroimaging show? Well, the CTA, this is the CTA, it shows the left M1 segment is occluded. But what does the CTP show? Does it show that there's a ischemic penumbra? Now, we're going to answer those questions in a separate lecture, but I just want you to understand this S plan and see how if you use this plan, this stroke plan, you can think of all these issues surrounding stroke. Another etiology or cause of acute ischemic stroke is small vessel disease. And this is caused by disease within small perforating arteries that arise from larger vessels, such as the lateral lenticular striate arteries. Remember, these arose, we talked about this in the last lecture, off the M1 segment of the middle cerebral artery. They can arise from other small vessels, such as the pontine perforators, which arise from the basilar artery. So here are those pontine perforators arising from the basilar artery. Now, small vessel disease is often thrombotic disease, meaning it's localized within the blood vessels, okay? It's not an cardioembolic stroke. It's not an embolus arising somewhere else. It's disease affecting the vessels in the brain themselves. This type of stroke tends to occur in deeper regions of the brain and brainstem. Small vessel disease, again, represents about 15% of all acute ischemic stroke. So here are both vertebral arteries. Remember, we talked about this before. They form the basilar artery. Coming off the basilar artery are these pontine perforators. And you could see that if we have a infarct or disease involving one of these pontine perforators, we can get a classic paramedian distributed pontine infarct. So this is a right paramedian stroke within the pons, which, although the size of the stroke is small, it's a very eloquent region of the brain. Remember, the pons is the middle section of the brainstem. Remember, we talked about all those high-density circuits going through the brainstem. Everything in this region is important, so a small stroke in this region can be potentially devastating. Now, similarly, other parts of the brain get blood supply from other small vessels. The caudate head gets blood supply from the medial lenticular striate arteries. Remember, these are the arteries that arise from the A1 segment of the anterior cerebral artery. The lentiform nucleus gets blood supply from the lateral lenticular striate arteries. Again, these are the perforating arteries that arise from the M1 segment of the middle cerebral artery. The posterior limb of the internal capsule is oftentimes supplied by the anterior choroidal artery. Remember, this was the third vessel that arose off the supraclavian segment from the last lecture we did. And the thalamus has penetrating branches that arise from the proximal aspects of both posterior cerebral arteries. So all of these deep gray nuclear structures in this white matter tract, the posterior limb of the internal capsule, have penetrating arteries, which, if they result in stroke, this is from small vessel disease of those arteries. Again, here's a representation of the thalamus. Multiple small perforating arteries supply multiple areas of the thalamus. Here's a representation of the midbrain. Again, multiple perforating arteries arising off the proximal posterior cerebral arteries supply regions of the midbrain. Again, these are very important structures in the brain. And these perforating vessels supply blood flow to this area of the brain that is densely packed with multiple tracts. So a form of small vessel disease stroke is lacunar stroke, okay? A lacunar stroke means it's a small stroke caused by small vessel disease, but there's multiple different types of lacunar stroke. Now, these are covered in the book. I'm not going to describe all of them, but what I want you to understand and think about when you look at lacunar strokes, I want you to remember pure motor lacunar strokes, and I'll explain why in a minute. So lacunar strokes are small strokes caused by perforating small vessels, as we discussed earlier. The most common lacunar stroke is pure motor hemiplegia, where you either have weakness or paralysis of the opposite side of the body. This is the most common form of lacunar stroke. And this is caused by an occlusion of the lateral lenticulostriate arteries supplying the posterior limb of the internal capsule. Now, why does this matter? Well, we discussed this earlier. Remember this gray matter? All the cell bodies of the brain cells live in this gray matter. Their axons transmit down into the brainstem or spinal cord, and they converge in this white matter tract within the internal capsule. So if we have a lacunar infarct, even though it's a small infarct, and it involves the corticospinal tracts that go down through it, which control motor movement, we can have opposite side weakness or paralysis. So again, this is important because you could have opposite side weakness and paralysis from a small vessel disease stroke. Oftentimes when people see that, they believe this could be caused by a large vessel occlusion, but this is actually caused by small vessel disease. Now, in an earlier lecture, we reviewed all the deep brain nuclear structures, and we'll go through this in greater detail again, but I just want to point out again that the internal capsule is located between the caudate head and the lentiform nucleus. The anterior limb and the posterior limb is located between the thalamus and the lentiform nucleus. Again, all of those fibers converge in the internal capsule. Similarly, a lacunar stroke that can affect the pontine region can also involve these tracts. So a pontine lacunar stroke can involve these tracts, and if they involve the corticospinal tracts, you have opposite side weakness or paralysis. So again, these are small vessel disease strokes causing major problems. Again, these tracts, as they converge from different areas of the cortex, they first converge in the internal capsule and down into the brainstem in areas such as the pons. So if lacunar infarcts occur in eloquent areas where all these tracts converge, even though they're small, they could cause devastating symptoms. So why am I saying it's so important to understand that? Well, remember, we're talking about small vessel disease as opposed to this. This is a clot that's being pulled out of a large vessel in the brain. This is the M1 segment. Notice if this M1 segment's occluded, neither of these M2 segments distal to the M1 segment fill, okay? Why is that so important? Because look at this. If this is an M1 occlusion, okay, it'll block blood supply to all of these areas of the brain. Why is this important? Because large vessel occlusions involve multiple cortical distributions of the brain. In fact, the hallmark, as we'll learn in a later lecture, of all large vessel occlusion is it typically involves the motor cortex and one other cortical distribution, okay? Small vessel occlusions don't do this because they're small. They don't affect all these vessels distally. So when we have a large vessel occlusion, typically the motor cortex is involved and one other cortical distribution, whether we have aphasia from Broca's area or Wernicke's area, neglect from the parietal lobe, gaze preference from the frontal eye fields, or visual disturbances from the primary visual cortex. Now, all of these different lacunar infarcts are going to be described in the book. I just want you to understand pure motor hemiparesis. And the reason I want you to understand this is, one, It's the most common. And secondly, it is not to be confused with a large vessel occlusion. Remember, a large vessel occlusion involves the motor cortex and one other cortical distribution, whether it's aphasia, neglect, gaze preference, or visual disturbance. So, atherosclerotic large vessel disease, as we said earlier, involves large vessels such as the internal carotid artery or the proximal cerebral artery or the proximal anterior cerebral artery. Here's plaque in the internal carotid artery. Now, this blood clot is local from this plaque. It arises from destabilized plaque. That's where that clot occurs from. Now, cardioembolic disease accounts for 20% of all acute ischemic stroke. There are many sources for cardioembolic stroke, but atrial fibrillation is by far the most common. And what AFib does is it causes the atrium to vibrate, and this clot actually ascends up into the carotid arteries into the brain. So when we see anterior circulation, large vessel occlusion, we believe most of that is cardioembolic in etiology. Okay. So we talked about large vessel atherosclerotic disease. We talked about cardioembolisms. We talked about small vessel disease. We still have to talk about undetermined etiology and other causes of stroke. So now we're going to talk about embolic stroke of undetermined source, or ESUS. Now, what ESUS is, it's a new term that's supposed to replace the term cryptogenic. The term cryptogenic basically meant we don't know what causes this stroke. Okay, there's no definite source of cardioembolism. There's no atherosclerosis or large artery atherosclerotic disease. There's no small artery disease. So we're basically saying we don't know. However, there's now persuasive evidence that says most of this form of stroke is thromboembolic. Okay, that's why we now want to use this new term called embolic strokes of undetermined source. Why? Because although we don't know what the source is, we know that it's likely thromboembolic disease, okay? Likely from cardiac abnormalities or other sources, okay? And these are the other sources. You can have plaque within the arch. You can have hypercoagulability within patients with cancer. We could have paradoxical emboli like PFOs, and on and on and on. This is a mnemonic from the book that goes over the different potential causes of ESUS, which include hypercoagulable states, plaques within the aortic arch, non-stenotic plaque. Now, when we say non-stenotic plaque, remember, clot arises from the plaque, so it doesn't have to be a large plaque. It could only be causing like a 20 or 10% stenosis, but if it ruptures, it could launch clot into the brain. Different shunts. Why do we use the term cryptogenic stroke? We need to use the newer term, okay, ESUS. We have to monitor patients for subclinical AFib. That's often missed. There should be established exclusion criteria for ESUS at your institution. You should have an ESUS order set so we don't miss these different causes of ESUS. We have to consider things like silent myocardial infarction and atrial high rate episodes. Now, one cause of ESUS is hypercoagulable abnormalities, okay? And this term reflects hematologic abnormalities that lead to thrombosis within the cerebral vasculature. Now, there are a lot of things that could cause hypercoagulation, and this mnemonic rate shape allows us to think of these things such as gene mutations, activated protein C, sickle cell, antithrombin 3 deficiency, thrombotic thrombocytic purpura, lipoprotein A, hyperhomocystinemia, and by the way, I find this very often in my patients, autoantibody syndromes, protein C and S deficiencies, erythrocyte disorders such as polycythemia vera. And then finally, we have a category where if these are not large vessel atherosclerotic disease, not small vessel disease, not cardioembolic embolisms, not in that category of ESUS, there is another category which is just referred to other causes, okay? Now, these are unusual causes of acute ischemic stroke. And what makes these different than the remainder of the causes is these typically occur in patients without the classic risk factors for stroke. And they include vasculitis associated with connective tissue disorders such as lupus. And unfortunately, this is a CT of a patient with lupus who has vasculitis and subsequent strokes. Other things that can cause this are infections such as endocarditis and cancer. Other things that can be included in this unusual causes category are arterial dissection, aortic dissection, moya disease, we're going to talk about that in another lecture, migraines, headaches, arteritis, reversible cerebrovascular vasoconstriction syndrome. By the way, this is a subintimal dissection. This is a vessel. Here's the lumen. This is the intima, or the inner layer of the vessel. You can see it's torn here or dissected, and we have a little flap forming in here. So this is a subintimal tear causing a subintimal dissection. Now, while this category is very small and accounts for only less than 5% of acute ischemic strokes, there's two things in this category I want you to remember. That's infectious endocarditis and aortic dissection. Both of these are contraindications to the use of IV TPA. So just remember those two. Again, infectious endocarditis and aortic dissection. By the way, if you want to know all the TPA restrictions, those are also in the book in a separate chapter. But you can know 90%, more than 90% of TPA restrictions by remembering the mnemonic TPA. So the T stands for 3 months. We don't want any of these 4 things within the last 3 months. We don't want a prior ischemic stroke, prior intracranial bleed, prior severe trauma, prior brain or spinal surgery. The P stands for permissible time frame. We need to know that the last known normal was less than 4.5 hours ago. And the A stands for anticoagulants. You cannot get TPA if you take any anticoagulant, such as Xarelto, Eliquis, except you can take it if you're on Coumadin and the INR is less than or equal to 1.7. Now this list actually covers greater than 90% of IV TPA restrictions. So just remember the word TPA, and you should remember 9% of the restrictions. If you want to know all of them, refer to the book, and we'll go over that chapter later in this series. So in summary, acute ischemic stroke is a very heterogeneous disease with multiple different underlying pathologic conditions. The goal, however, of all acute ischemic stroke treatment is to restore blood flow to the brain and restore flow to that ischemic penumbra, that threatened region of the brain that's still alive but is non-functional. Okay? In order to accomplish this goal, we have to understand the different causes of acute ischemic disease or acute ischemic stroke. And best way I know of to think about all these things is to remember your stroke plan, okay? Always consider the components of the stroke plan when evaluating stroke. These components will help you decipher the complexity of stroke. So again, the S stands for source. Is it embolic or thrombotic? The P stands for pathophysiology or etiology. Is it cardioembolic? Is it atherosclerotic? Does it have undetermined etiology, ESUS? Is it small vessel disease, or is it everything else? Remember, in everything else, infectious endocarditis and aortic dissections are contraindications for TPA. Where's the location? What area of the brain is affected? Is the frontal lobe, the parietal lobe, the temporal lobe, occipital lobe? Is it cerebellar? Is it thalamic? Brainstem. The arterial territory involved. What arteries involved? Is the internal carotid artery, the MCA, ACA, vertebral, basilar, etc. And neuroimaging. So what does the neuroimaging show? Okay. And by the way, this location of where the stroke occurs will also determine the patient's symptoms. So I think that concludes today's lecture. Again, if you found this informative, please click the like and subscribe button. Thank you very much for your time and your support. Also, one last thing, if you have any questions, all of this stuff is covered in the book. Thank you very much.